Good afternoon, everyone. For those of you on the East Coast and for those of you on the West Coast, good mid-morning to you. Welcome to the CanVector National Thrombosis Seminars. My name is Eric Sang. I'm a hematologist who works at St. Michael's Hospital at the University of Toronto. We are delighted that Dr. San Filippo from Washington University School of Medicine at St. Louis is with us today. Before we get into her session, just a few reminders about these sessions. These are monthly seminars that feature state-of-the-art topics in thrombosis and venous thromboembolism with both Canadian and, in this case, international experts. Video recordings are online, and please make sure to claim your Section 1 credits through MOC. This is the planning committee. And today's presentation will be about anticoagulant-related bleeding in patients with cancer, an issue that came up for me this morning in clinic. So look forward to this session from Dr. San Filippo. Just an introduction, she's an associate professor of medicine in the Division of Hematology at Washington University School of Medicine at St. Louis, and a staff physician in the Hematology Oncology Department at the John Cochrane VA Medical Center. She specializes in thromboembolism, completed her heme-onc training at the same institution where she also earned a master's in population health sciences. Research focuses on VTE and anticoagulant-related bleeding, as particularly in cancer patients, leading an ASH and NIH-funded study to look at predictors in this space. And she's also the chair of the ISTH SSC for hemostasis and malignancy. Thank you, Kristen. Please take it away. These are the objectives for today.
Great, thank you. Let me just pull up my slides. Okay, and let me get my pointer ready. Well, thank you kindly for the invitation. I'm really delighted to have the opportunity to present. As mentioned, so my research focus is really more on the prediction of anticoagulant-related bleeding, and that will come out in the talk today, where that's really more of the focus of the talk. We are moving more towards understanding outcomes after anticoagulant-related bleeding and treatment, but we'll more so focus on risk. I am an associate professor of hematology at Washington University in St. Louis, and I spend part of my time actually at our Veterans Health Administration Medical Center caring for our veterans. This is my disclosures, and the research funding is highlighted throughout my talk today, so that is relevant and does pertain to my talk, but nothing else. So just a little bit of an agenda today. Some of this will be kind of clear review, some new or recent information. So we'll start to talk about what are the common indications for anticoagulant therapy in patients with cancer. What is the incidence of anticoagulant-related bleeding in cancer, the clinical implications of the events that occur, kind of current durations of anticoagulant therapy, and then at the end, some identification of risk factors and next steps moving forward. So starting out with indications for anticoagulant therapy. So, not surprisingly, the patients with cancer have the same indications for anticoagulation that the general population does. The two most common indications are venous thromboembolism and atrial fibrillation, with the exception is that the cancer patients have an indication for primary prophylaxis for an extended period of time, 6 months in the ambulatory setting, where we don't see that necessarily in the general population. Of course, you have your primary treatment phase for venous thromboembolism, which generally refers to that first 3 to 6 months of treatment, and then potentially long-term secondary thromboprophylaxis, which in some patients is indefinite. Atrial fibrillation will look as in the past 5 to 10 years have had publications showing that the risk of such is higher in patients with cancer. And then, of course, less common indications like peripheral artery disease and valvular heart disease, where you may see some anticoagulants like rivaroxaban 2.5 milligrams for PAD. So just focusing on the two more common indications, and then we'll narrow into venous thromboembolism. which is currently where I spend most of my time, although we are branching to the atrial fibrillation. So if we look at the Danish registry cohort, so this publication by Mulder and colleagues now 4 years ago in Blood, demonstrated that if we take patients with cancer, they had 500,000, and compared them to 1.5 million matched controls and look at risk of venous thromboembolism, that in the first 6 months of cancer diagnosis, it's 11-fold higher than the general population, and it maintains a heightened risk at 12 months with 8.5-fold higher risk. We see that that risk is modified by cancer type, and so some of the hematologic malignancies like Hodgkin's disease and multiple myeloma having higher risk. When you look at the solid tumors, pancreatic cancer, the upper GI cancers tend to have higher risk. And then some of the more common cancers, thankfully, like breast and prostate, have risk that is still above the general population, but lower than some of the other cancer types. The other thing that they found in the Danish cohort was when they looked at the change in incidence from over a 20-year period from 1997 to 2017, they found that in cancer patients, the incidence increased about threefold, but in the general population stayed relatively the same. And so it is a rising problem leading to more and prolonged anticoagulant therapy use. If we look at atrial fibrillation as mentioned, again, in the past 5 to 10 years, publications have demonstrated that patients with cancer also have a higher risk of developing incident atrial fibrillation. So if you look at the left of your screen, this was a study that took patients with cancer and followed them from diagnosis up to 8 years and compared them to patients without cancer. And these patients had a 63% higher risk of developing atrial fibrillation. Just like with venous thromboembolism, you can see on the right that the type of cancer does matter in terms of risk. And so we see our key player, multiple myeloma, again, also having a higher risk of arterial events, just like the venous events. Again, upper GI cancers, other hematologic malignancies, kind of rounding out up here in the top 5. And then cancers such as prostate cancer, breast cancer, kind of again being closer to the risk seen in the general population. And we care about these venous and arterial events. So this is almost a 20-year-old publication now, a smaller study by Karana and colleagues that looked at what were the causes of death in patients with cancer. And at that time, the leading cause of death was, of course, cancer progression, but tied for second was a composite of arterial and venous thromboembolic events, along with infection. And so really kind of the movement towards expanding anticoagulant indications to not only treat these events, but to prevent them. And so when we're trying to do some of this, so I really want to focus on the highest risk period for anticoagulant-related bleeding, and that centers around therapeutic anticoagulation use. So I won't go into the primary prevention prophylactic dosing. So for those of you who have heard me talk before, you've probably seen this slide. This is just a timeline of what has happened for treatment of cancer-associated thrombosis over the past 2 decades. And really the story started with the publication by Prandoni and colleagues in 2002, where it was demonstrated that if you take patients with cancer and compare them to those without, both sides having a new venous thromboembolic event, patients with cancer had a 3-fold risk of recurrent venous thromboembolism within that first 12 months. And they had a 2-fold increase in the risk of anticoagulant-related bleeding. And so that really motivated the study of anticoagulants that could decrease the risk of recurrent venous thromboembolism, but also potentially bring down that risk of anticoagulant-related bleeding. And so the first series of studies focused on low molecular weight heparin took place over about a decade from 2002 to 2015. And of course, the comparator at that time was warfarin. And if we take the meta-analysis of the key studies during that time frame, we can see that they were quite successful in reducing the risk of recurrent venous thromboembolism. So from 11.4% with warfarin down to 6.8% with low molecular weight heparin. But they did not really shift the safety outcomes in terms of anticoagulant-related bleeding. Now, not necessarily fueled by this, but around 2012, the direct oral anticoagulants started to become widely available and were quite attractive compared to low molecular weight heparin because of the ease of oral use, so the decreased morbidity from daily injections, but also noting that there was room for improvement, and they also were better than warfarin outside of the cancer population. So you can see some of the key studies from 2018 to 2022, looking at their performance versus the standard of care low molecular weight heparin, and again, quite successful in reducing the risk of recurrent venous thromboembolism even further. So continuing to move the progress further with about a 30% reduction in risk. But similar to the low molecular weight heparin story, direct oral anticoagulation did not improve the risk of major bleeding compared to the standard of care at the time, with really no difference seen there. So if we summarize kind of what happened over the 2-decade period, we've been quite successful at driving down the risk of recurrent venous thromboembolism from warfarin all the way to direct oral anticoagulants, but we have not been successful in reducing the risk of major bleeding. And this does not include our clinically relevant non-major bleeding numbers, which drive those numbers that you're seeing even higher, as those are still significant events. So why do we care about these bleeding events? So we can start by looking at the case fatality rate of anticoagulant-related bleeding in cancer. So this was a meta-analysis done of almost 30 studies, so 15 prospective cohort studies and 14 randomized control studies. You can see that if you look at the nearly 5,000 patients, about half were on low molecular weight heparin, but almost 20% were on the direct oral anticoagulants. And overall, the case fatality rate was about 9%. The part that I like the most about this study is when they separated case fatality by randomized control trials versus the cohort studies. So cohort studies, you have to be in the cohort. You have to be in the database that the investigator is looking at. So when I look at VA studies, we take all comers. We're not excluding anybody generally. But in randomized controls trials, you have to be healthy enough to enter. So if you think about some of the studies that I just showed you, very commonly contraindications were primary brain tumors, metastatic CNS tumors, patients with significant renal disease, patients with thrombocytopenia, anywhere from exclusions of 50,000 to 100,000, patients who had an overall worse prognosis with decreased life expectancy. So all of those patients were really excluded, and we see that reflected in the severity of fatality when a patient has a bleeding event. So in the cohort study, it's 14.2% case fatality, but only 6% in randomized studies. So while that shows us one thing, this is probably what we're seeing in everyday practice when we see these patients in clinic. We used our VA data, which I'll talk a little bit about later and kind of explaining the cohort to you, but just to stay on the topic of mortality. So this is solid tumor. We had similar findings for hematologic cancers that actually I worked on with a fellow colleague, Zufei Wong, who I also had the pleasure of training with. But if you look at anticoagulant-related bleeding, so we wanted to see how that increased the hazard of death. We adjusted our models for other known associations with death, so age, cancer type, stage, frailty. So there's a VA frailty index that works quite nicely in our data to predict death. And what we found was that patients who had any anticoagulant-related bleed that resulted in hospitalization had a 3-fold increased risk of death, even after adjusting for these other factors. If we look by site of bleed, as intuitively expected, intracranial hemorrhage carries a higher risk, a hazard of mortality at almost 6-fold. And then if we look at GI and GU, again, those remain significantly associated with GI being higher than GU. So even if death is not the outcome, these are what happened to the patients in the HawkUSI VTE cancer study who had a major bleeding event. And so again, patients healthy enough to be in a randomized study, and this was the severity of their morbidity associated. So about two-thirds of them were hospitalized and required transfusion. If they were hospitalized, the majority of the location of the hospitalization required intensive care unit stays. 1 in 4 patients had interruption in their cancer-directed therapy, which if you're treating a palliative patient may not be as meaningful, but if you're treating a patient who's on a time-sensitive curative intent regimen, that may be more impactful to their long-term outcomes. 1 in 5 patients, excuse me, required procedures. And even in this, so-called healthier population who meets criteria to be in a randomized study, they noted a death of 5% of the patients. So what do the guidelines recommend in terms of duration, and how long should we really be focusing on bleeding risk? I took 4 of the larger guidelines. There are many other guidelines. There are many country specific guidelines. But if we look at the American Society of Hematology, the American Society of Oncology, the CHEST guidelines, and the NCCN guidelines, all with a high level of evidence, they recommend anticoagulant therapy, depending on the situation, for 3 to 6 months after thrombosis diagnosis in cancer. But what happens after that 3 to 6 months is a bit less clear because it's driven by a lower level of evidence. So what is generally recommended is that after, let's say, 6 months of therapy, so the randomized studies I showed you, all of them at least treated the patients for 6 months. After that 6 months, it's recommended to do an individualized risk-benefit evaluation. And factors that argue for continuation of anticoagulant therapy include ongoing active cancer. So the risk factor that caused the thrombosis is still present. They have advanced disease, such as metastatic or progressive disease. They're requiring systemic treatment. They have historical thrombotic events. They've recurred on anticoagulant therapy. All of those things argue for continuation. Some of the factors that argue for termination include the cancer being in complete remission. So you've removed the risk factor, they've received curative therapy, they have no advanced disease, they're not receiving treatment, potentially some of these lower risks. So I showed you in the beginning that the risk of thrombosis with breast and prostate was above the general population, but much different than some of the hematologic and upper GI malignancies. But then also this high bleeding risk as an argumentative factor for termination of therapy. And so what is high bleeding risk? Well, in non-cancer populations and potentially in cancer populations, we have ways of identifying those patients. And so very commonly in atrial fibrillation, we have risk models that are utilized to help in decision analysis on whether or not a patient should be started on anticoagulation. That's a bit different of a scenario because those patients haven't had the outcome of concern yet, in fairness, but these are widely accepted risk models that have been validated with adequate performance to inform clinicians. We have a similar example in venous thromboembolism patients with VTE bleed, and then there was a risk score CAT bleed for patients with cancer that was developed. Now, when we looked at some of the common available risk models within our VA data for prediction or for just performance of predicting 12-month anticoagulant-related bleeding, so bleed that requires hospitalization, We measured that by looking at the model's discrimination. So the discrimination is statistically represented by the C statistic, and really is the ability of your model to say that patient and that patient are going to bleed by 12 months, and that patient's not going to bleed at 12 months. The score ranges from 0.5 to 1, and 1, it would be perfectly able to predict the patient every time. 0.5 is more similar to a coin. And you can see that some of these scores have C statistics within the 0.5 range. And so most people would classify that as mediocre performance. We also looked at a 6-month interval, and some numbers like VTE bleed got slightly better, but not significantly different from the numbers I'm showing you here. So arguing for room for improvement. If we look at some of the common models, and I'm showing some additional ones that I didn't show in the first slide, you can see there are themes and risk factors. So patient age, as age increases, the presence of anemia, history of bleeding, cancer, which all of our patients of interest have cancer, and in the situation that I study, hypertension, especially if uncontrolled, kidney disease. All of those factors are present in at least 50% of available models, suggesting a pretty clear theme and consistent risk factors. But do they work in patients with cancer? If you think about anemia and you think about your newly diagnosed patients with cancer, some studies show that up to 90% of patients with cancer, especially if on treatment, have anemia. And so can anemia really discriminate between bleeding risk if everybody's anemic? And so we wanted to use our real world cohort, which is our veteran data, to try to answer some of these questions and see if we could kind of fine tune quantification of risk, which is what we're working on now. So just a little bit about our data set. So again, it's United States veterans. That means that the majority of our patients are male, about 98%. Using kind of methods, we did our best to identify a population of patients with active cancer, a new venous thromboembolism, because we know that bleeding risk is higher really in that first year. You kind of declare yourself as a bleeder or not. A new prescription for anticoagulant therapy. So we didn't want patients who had recently been on anticoagulation. We ultimately ended up with a cohort of 11,151 patients. The majority of those patients do in fact have solid tumors, which kind of goes along with the VA population. Some of the more extreme hematologic cancers are being fee-based out or cared for at academic institutions, depending on the complexity of their treatment. We looked at the 12-month cumulative bleeding incidence, and the bleeding events that we looked at to improve our positive predictive value of ensuring that the event we were looking at was a bleeding event were really events that required hospitalization. So what that means is that this number is artificially low. The patient that you see in clinic with bleeding that comes in for an outpatient transfusion and you're able to manage everything without admission, none of those patients are included here. If we look at our anticoagulant trends over time and what our patients are receiving on, they nicely go with that timeline that I showed you in the beginning. So early on, patients were still receiving about 50-50 warfarin and low molecular weight heparin, but as evidence for the direct oral anticoagulants increased by 2020, 80% of our patients, their first outpatient prescription was for a direct oral anticoagulant after venous thromboembolism diagnosis. So of our 8.5% of bleeds, so that was 869 patients out of just slightly over 11,000 patients. Over half of our bleeds are gastrointestinal, 20% are genitourinary, almost 11% intracranial hemorrhage. So 1 in 10 hospitalized bleeding events, intracranial hemorrhage, and then kind of the other number, which is about 12%, makes up the other bleeds, the less common bleeds that we saw. When we look at those traditional risk factors, especially the ones that I showed you were present in over 50% of available models, so they performed well in all of those. We wanted to see how they performed in our cohort. And you can see that based on the p-values and the hazard of bleeding, that they are significantly associated with bleeding. This was kind of we took the definition of these variables based on how they were used in existing models. So we haven't modified the definition. So age per year increase, which we've also looked at per decile increase and shows a rising risk. A chart documented history of alcohol abuse was associated. Anemia, and we used a hemoglobin cutoff of less than 10 based on what some models were using. Concurrent antiplatelet use, a bleeding history, the presence of chronic liver disease, and then we looked at hypertension, and we looked at uncontrolled hypertension, which ended up being a stronger predictor. We also looked at some of the cancer-specific factors, and so when looking at cancer type, the way that this is in the model right now, so these are all multivariable analyses, so adjusted for each other and other bleeding factors. This is each cancer type compared to all other cancers. So CNS malignancy compared to all other types. We've looked at this as a categorical variable with prostate as the reference as well, and shows relatively similar risks. So if we look at CNS cancer, a twofold increase in the hazard of bleeding at 12 months. When we look at gastrointestinal, if we looked at upper and lower separately, they were both associated with risk. But then we further specified this group based on the results of some of the randomized studies, such as Caravaggio, which showed that really the GI patients that were bleeding on the DOACs were patients that had unresected tumors. So using surgical codes, we teased out the patients who had had their primary tumor resected. And those patients, the association went away in terms of the GI malignancy and anticoagulant-related bleeding. It was the patients that had no prior resection, so presumably had their primary tumor intact, that had a higher risk of bleeding. So twofold increase for upper GI and almost the same for unresected lower GI, such as colon tumors. Also, almost a twofold increase in the risk of anticoagulant-related bleeding for genitourinary. The active use of chemotherapy was a risk factor for anticoagulant-related bleeding, and so was metastatic or advanced cancers. The thing that we looked at kind of more recently was whether or not, if we identified factors where we said, okay, maybe they're not completely modifiable, but they could be indicators that you can pursue a workup to try to optimize your patient. And this is commonly done in the chronic liver disease population. So these patients will get started on beta blockers, H2 blockers, have kind of anticipatory scopes done to look for varices, which are then banded if they're at high risk of bleeding. So it's common practice in that population. And what we asked was, can we start to think about doing the same thing in cancer patients? Can we optimize them at the start? So looking at, we can't change age. So we looked at the ones that are highlighted red and are actually working on liver disease, because with the example I just shared you, maybe they could get an EGD to look for varices. But in looking at some of these variables where we thought we could do something with these, or we could use this information, alcohol abuse, anemia with a hemoglobin of less than 10, antiplatelet use, and uncontrolled hypertension, and tried to figure out, of the bleeds we observed, what percentage was attributable to these individual risk factors. And so statistically, the way that this would work is if you could erase all of the anemia, for example, then you would take away 12.2% of the observed bleeding. And we can't erase all of the anemia, and at least half of the anemia could be from the underlying cancer, but maybe the other half of the anemia is assigned to you that the patient has a slow GI bleed. And if you intervene then, as opposed to waiting for the major bleed, you can improve outcomes. Uncontrolled hypertension, another great example, we have pharmacologic therapy that can modify this variable. And whether or not that would improve outcomes, we don't know. I think that's an unanswered question. So what are some of the next steps in terms of our efforts and just thoughts in general to improve anticoagulant-related bleeding? So we are working on developing a risk model to better quantify bleeding. We're taking some of the identified variables and trying to look, can we modify the definition to get a little better discrimination per variable and then together? Can you do personalized anticoagulant therapy for patients with cancer? So this was the example that I just shared. Can we modify some of these risk factors at the start of anticoagulation? Can we so that flow chart that I showed you, if the patient is low risk for recurrence, but higher risk of bleeding in a risk benefit analysis, it would favor stopping. Can we dose reduce after 6 to 12 months? And so the APICAT trial was just recently published about a month ago, looking at that exact question, which I have a slide after this to kind of incorporate that. And then we do have trials looking at factor 11 inhibitors for cancer-associated thrombosis, with the hope that they will do just as good for prevention of recurrent venous thromboembolism, but this time we'll actually target a lower bleeding risk. So just to kind of take that next steps and show how it could potentially work. So this is work under review by our hematology fellow, Dr. Mohammed, who did a meta-analysis of the studies that looked at dose reduction in patients on anticoagulant therapy with cancer-associated thrombosis. And so the majority of these patients are patients that participated in the recently published APICAT study, but then also took some patients identified as having cancer from Einstein choice, and then the EVE study, which was similar to APICAT but published 2 years ago. You can see in APICAT that looking at composite bleeding, so major and clinically relevant, there was a reduction in the in bleeding with dose reduction, so making it an attractive option. If we look at all the data together, it doesn't meet statistical significance, but I do think that these findings are enough to drive argument as, okay, this is a tool that we have in our toolbox, and we should consider that, especially in patients where we're worried about the risk of bleeding. It may be that we need longer term follow-up to see a bigger reduction. So if you take the recently published RENOVE study that was presented at ASH in December, you can see that their follow-up over 5 years really showed us that nice reduction from 15% in patients that were on full dose down to 9.9% in patients on the reduced dose when looking at composite bleeding. So again, maybe we just need more time. So I think there is still a lot of progress to be made. There is still a lot of research to be done looking at outcomes in this patient population. Furthermore, what happens to them and how do we improve outcomes after the event. But until my work on prevention is done, I'll kind of expand my efforts otherwise. I'm happy to answer any questions. Thank you guys again for the opportunity to present to you and taking time out of your day to listen.
Thank you so much, Kristen. That was a really wonderful summary and amazing work in a really important area. I'll invite the attendees to put your questions in the chat. But while you're all thinking or finishing your sandwich, maybe I can start with a question. You mentioned you're doing some work trying to develop a risk model. In your mind, do you think that this would be best applied? Like, at what point in the treatment course would these types of models be best applied? At the beginning of treatment, like 3 to 6 months when we're thinking about like what to do at that point? What are some of your general thoughts around that timing question?
Yeah, so I think it's a good question. Currently we're using the first 12 months of data. But that's really to allow adequate power to more so identify the factors. But I think most people are very unlikely to change their course of action at VTE diagnosis, because our data really supports, 6 months of anticoagulation in most patients. The maybe loophole in there, or that could kind of help decide duration of therapy would be, a controversial area, which if we're coming to ISTH, our SSC will have a nice debate, but about like subsegmental incidentally diagnosed pulmonary embolism. Another, kind of debatable area is distal deep vein thrombosis. And so I think that there is some room to include some of this prediction for those controversial events. But for most patients, it's really probably going to be maybe at the 3-month mark, but definitely at the 6-month mark.
I think that makes sense. Treatment, that's always the difficult decision point, I think.
Right.
Um, uh, if anyone has questions, please feel free to enter them in the chat. I guess I can ask another question. Um, in your study, you were mentioning like the bleeding rates, and by tumor type. Did it matter what type of anticoagulation like agent they were getting, or
Yes, so I didn't show that data because we're still fine tuning it, and actually kind of have been working the past week with my statistician to try to get it on time. But what we did show is if we look at anticoagulant therapy, and use warfarin as the comparator, that the direct anticoagulants had about a 25% or so reduction in the risk of bleeding, and pretty similar with low molecular weight heparin compared to warfarin. So we do see that type of anticoagulant being important overall.
is
I
it
see some questions too. I
Go
see,
ahead. Yeah.
I see Mark asked a question. I think, okay, so his question is whether or not we should really be focused on the risk factors with the highest attributable risk, versus the highest hazard ratio. And so I think it's a mixed answer. So first, what I can't do with my work, what I'll never be able to do is prove cause from the work that I do. And I think that some of these things, like anemia is a great example. There are some papers that argue anemia in and of itself is a causal factor for bleeding, and that if you correct the anemia, that you reduce bleeding. But for the most part, it's probably it's not causal, that there's another problem. And so I think it's going to be difficult to tease that out. But I do think attributable fraction is a more lucrative place to start if you can get more bang from your buck by focusing on it. I have not seen evidence in the cancer population that shows that this reduced risk. I think it's an amazing opportunity for a clinical trial because you're not intervening, you're just potentially providing, a little bit tailorized therapy. So I would be extremely, that's kind of a goal is to, or an aim to look at doing that in a trial in the future. If we optimize some of the identified risk factors, are we improving outcome without changing any of our treatment? And I'm happy to collaborate. The next question I see is from Joseph Shaw. Let me see, hold on. So he's asking, in the model I presented near the end, were we able to look into interactions with anticoagulant types? So I think that's what you asked, Eric. And so we didn't look at interaction. We haven't looked at interactions between bleeding risk factor and anticoagulant yet. We've thrown anticoagulant type in the model and see that type of anticoagulation matters. But as with our low molecular weight heparin versus direct oral anticoagulant data, you're exactly right that the DOACs are more important in GI malignancy related bleeding, and especially unresected tumor. So no, that is something that we are working to do as well. And then looks like Ben Lai has a question. So it seems that cancer VTE is better studied than cancer and AFib with stroke. Is there any difference between DOACs and low molecular weight heparin for this indication? So I have not seen that data in terms of differentiating risk in atrial fibrillation. We have a very large population of patients with atrial fibrillation and cancer in the VA that we've started to look at, but I haven't seen anything yet. And the majority of the patients that I have not seen AFib patients prescribed low molecular weight heparin because of concerns. They've mostly all been on DOACs, but I think it's an interesting question and one that I can definitely add to our bucket to look into. And then it looks like another question from Leonardo Brandau. I apologize if I'm mispronouncing anybody's name. That is a very weak part in my elementary learning history. So that is the effect of anemia and its association with bleeding disappear depending on platelet count. So we have looked at platelet count. We've looked at it in different ways. We've kind of taken the standard definition, which is 50,000. We've put it in continuously. We've categorized it. But when we throw it in, actually the platelet count loses significance when we're adjusting for some of these other things. And anemia kind of holds fast whether or not platelet count is in there at all. But good question. And then I think that the last question that I see from Ismail, have you looked at cancer site or type of cancer therapy and risk of bleeding? So cancer site, like that is a future goal, is to look at the interaction. Right now, we just look at yes, no with both variables in the model, but I think that's important based on the randomized studies that we have. In terms of type of cancer therapy, so right now chemotherapy is grouped together. We did in univariate analyses look at some of the types of cancer therapy that have been associated with bleeding, especially based on Zufei's work, like the TKIs. Hydroxyurea has some data, the BTK inhibitors of course. And I really think it's because of, especially with the BTK inhibitors, lower numbers, that we aren't seeing a big signal there. We do see it with some of the TKIs in the solid tumor patient population, but once we throw in type of tumor, so those are often being used, especially for like GU tumors, once we adjust for that risk, it goes away. And that could still be a number thing. The hazard ratio still favors risk, but it's not significant.
Okay. If there's any more questions, I'm sure Kristen would be happy to answer by email.
Absolutely.
Otherwise, thank you, everyone. Please do fill out the evaluation and look forward to seeing you all next month. Thank you.
Yeah, thanks for the invite.